So, it is so great to be here today with you. We are here at the University of the Pacific, Stockton campus, and I'm here today with a colleague that has been at Pacific since 2005.
Yes, yes.
2005. Okay, Dr. Rajul Patel, but he also goes by Dr. Raj.
Just Raj is fine. Yes, yes. Formality's not needed.
And you actually are an alum of the University of Pacific Long Pharmacy program where you earn a doctorate in pharmacy.
Yes. So I did both my PharmD here, my doctorate of pharmacy here, and also my PhD here.
Wow, I didn't know you had done all of them.
Yes.
So you're Pacifican 3 times?
I'm 2 times. Undergrad, I did back east.
Okay.
Yes.
So back east, now you did Johns Hopkins University,
Correct.
right?
I got my bachelor's in psychology and biology there.
Yeah,
Yes.
great. So now you are an associate professor. And exactly what is the title of your associate professorship?
So actually full professor.
Okay.
Yes, yes.
All right then. Full professor.
Full professor. Full professor of pharmacy practice.
Okay. How many years have you been at Pacific?
So this is going to be my 16th year on the faculty.
Okay, wonderful. Now tell me a little bit about your time at Pacific. What has been the opportunities that you've had here and the things you've seen change over the course of the time that has really 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 sparked your imagination, and why do you continue to be here?
Thank you for asking. So I think one of the big changes I've seen from being a student and even in my early years as a faculty member to now, especially in pharmacy, is this focus on experiential learning. Prior to that, even when I was going through school, we had some exposure, some hours that we would do in different pharmacy settings prior to graduating, but it was very little. And most of my experience was limited to the community setting. And now students, when they graduate, they have to do community and hospital and ambulatory care. We have students doing geriatric care. And so they get a breadth of taking what they learn in the classroom and actually applying it or seeing it come to life in an experiential setting. So that has been a big difference. And I think for many people, that's when you feel more engaged and you feel like you understand what's being taught because you're seeing the application to people in an unscripted setting.
Wow. So I had an opportunity to see you in a community experiential learning setting. It was a diabetes clinic that you were running along with a group of other Long Pharmacy faculty, and it was one of the most beautiful community engagement settings that I had ever seen. You were in the really southeast Stockton area, situated at an African American church community. There were buses, van loads of people that were coming in from throughout the community by the largest Latinx advocacy community-based organization, which was El Concilio. And that particular engagement that we knew you were doing with also a funded, sponsored partner, which was the Abbott Fund, and you could talk a little bit about that. But it was a diabetes clinic in one of the most economically impoverished parts of a city that has seen waves and waves of divestment, as well as what I would call a lack of community investment in the most marginalized communities. And you held a diabetes clinic as well as obviously an immunization clinic there. Talk about that work. Talk about your relationship, not only as a pharmacist and as an educator, to that work. And I just want to hear more about not only what it was, but I want to hear about your path that led you to do that kind of pharmaceutical education work.
Sure. So some context is, Stockton is not a very big city. And just a few miles from here, you have parts of Stockton that are very underrepresented in terms of access to healthcare services and in terms of individuals who can accommodate the language needs of those residents. So our focus with the diabetes care clinics is really on South Stockton, in which the rate of diabetes and prediabetes is disproportionately high. How high? Well, about 3 of every 5 residents in those areas actually have prediabetes or diabetes,
Mm.
many of whom might not have insurance or they're underinsured, many of whom maybe have been diagnosed but don't
Mhm.
have the proper access to care that they need because their providers don't speak their language. And so we are making a concerted effort, and it's a three-pronged approach. The
Mhm.
first one you participate in. So what we're first trying to do is build relationships with these communities because for many years we have not really had those relationships, and so
Mhm.
we're trying to build trust. So first thing is the health fairs.
Mhm.
The health fairs are sort of comprehensive service-based health fairs in which a variety of different services are being provided, and as you mentioned, partnerships are being created with El Concilio, Emergency Food Bank,
Mhm.
APSARA. And so what we do in terms of the services, we will first see if they have prediabetes, or we will do a blood glucose check to see if they have or at increased risk for diabetes.
Mhm.
Blood pressure measurement is critical because
Mhm.
many people who have diabetes also have
Mhm.
undiagnosed hypertension.
Mhm.
Cholesterol as well, right?
Mhm.
With individuals who have diabetes, they often refer to them as having syndrome X. So they'll have metabolic disease, hypertension, high cholesterol, and then the diabetes. So
Mhm.
individually, those are problematic.
Mhm.
When you congregate them, right, the risk increases exponentially for heart disease and
Mhm.
stroke. We will also provide a variety of immunizations.
Mhm.
And so there are some immunizations that are recommended for individuals with diabetes, but they might not be covered or they might be quite expensive. So all of our services are free of
Mhm.
charge. So we will do that. Now, the health fairs are the first thing. Now, if they have a provider and we do this review of their health state and their medications and we identify issues, with their permission, we will actually contact their provider, share with them what we found, and make a recommendation for how those issues can be resolved.
Mhm.
But what happens if they don't have a provider, right?
Mhm.
So what we built into is a process where we have social service referrals.
Mhm.
So we will find out before they leave, do you have access to a provider? If not, we will make a referral to community medical centers where
Mhm.
individuals who are un or underinsured can actually get access to healthcare
Mhm.
services, and how much they pay is based on a sliding scale. If they have food insecurity issues,
Mhm.
Emergency Food Bank partners with us, so they will give them a box of fresh produce, fruits and vegetables, dry
Mhm.
food that are healthy, so they have that, and they will also see if they're eligible for some of their other programs. Access to providers. Maybe
Mhm.
they have a provider, but they don't have transportation.
Mhm.
Maybe to go to the doctor, to go to the pharmacy. El
Mhm.
Concilio actually provides free medical transportation. So
Mhm.
we will ask them a series of questions, and if any of these are issues for them,
Mhm.
we will make sure that the proper referral is met so that they have what they need to feel empowered to take care of their health. That's the health fair. But then what happens if we do the screening and someone's identified as having prediabetes?
Mhm.
So the question I always like to ask is, so what? Why are you doing this? It's not
Mhm.
enough to know that, okay, they have a score
Mhm.
of X and therefore they're increased risk for diabetes. What are you doing about it? So our next phase we're actually rolling out right now
Mhm.
in these same underserved communities.
Mhm.
What we're going to do is we're going to actually embed the CDC's lifestyle prevention program, which is called the Diabetes Prevention Program.
Wow.
And it is a longitudinal program, quite a heavy commitment, because
Mhm.
individuals would have to participate over the course of a year in 22 to 26 classes. So almost every other week.
You
We're
said 22 to 26 classes?
That's correct.
Wow,
So
that's
for the
like a degree.
it is, right? For the first 6 months,
Yeah.
it's a weekly commitment, and thereafter it's every other week or monthly.
Mhm.
But we are going to be facilitating those classes. So if they have prediabetes, they can opt into these classes. Are these classes offered in the community? There is nowhere else in San Joaquin County that offers the diabetes prevention program.
So when you say we're going to be facilitating these classes,
Mhm.
Dr. Patel, exactly what does that entail?
That means we have a group of faculty that have all gone through the certification process to be facilitators of this program.
Mhm.
Those 22 to 26 classes are going to be
Mhm.
taught by us, the faculty and the students who are also going to be trained. We are going to go in these communities. We're not going to bring them to Pacific.
Mhm.
We're going to have these classes in those same
Community engagement.
Yes, they're going to be embedded in those areas.
Mhm.
And we are going to facilitate these classes. Usually the classes are a cohort of 12 to 15 participants that we will follow and
Mhm.
work with over the course of the year, with primary goals about how to increase their
Mhm.
healthy eating and
Mhm.
active living, increase exercise, reduce their weight, and improve their blood glucose control, glycemic control.
Wow. So there's a lot there that I want to unpack a little bit. In my mind's eye right now, my brain is going to several pathways that I want to have go with you.
Okay.
One of them is how you do the work, um, and the other one is why you do the work. So, but before I get to the how, because the how has to do that there's a particular way, even with what you described, in going in community, and seeing the community as a site of asset, seeing the community as a site of scholarship, because who knows their stories and their narratives better than they do themselves, seeing the community as a place of learning, and that the university, in regard to its resources, and what we have, actually goes into the community, and the community itself then has this kind of, there's this mutual exchange, and what I call kind of this mutual beneficial experience that happens. So it takes it. It's a complete juxtaposition of what how higher education in a Western context has understood as being the site of knowledge, the fountain of expertise,
Right.
and yet we flip and inverse it a bit, where the community then becomes the asset.
Hmm.
The community can tell you what it needs. The community can tell you what's going on. They can tell you whatever, and the university and its scholarship and its research and its personnel and the things that it does goes in with the community, and not and that's where magic happens. And so that how piece is is an inversion of how we have done work in a higher education context.
Yes. Yes, it's so true. We are trying to remove barriers and make community informed decisions, right?
Mm.
As opposed to building something. This is not the field of dreams where you build it and they will come,
Mm-hmm.
right? Instead, we need to hear from them what they need, and then we need to find ways to supply what they need.
Mm-hmm.
It bothers me that in this country, which is so asset rich,
Mm-hmm.
that our healthcare system is so poor.
Mm.
It is poorly integrated and it is not accessible to most people for a variety of reasons.
Mm-hmm.
And as a healthcare provider myself, when you see that individuals come to the pharmacy and they have a chronic condition, but there's a medication that can treat it or prevent it, and
Mm-hmm.
they can't afford it, it kills me. It really bothers me. And so looking at ways to remove some of these barriers to make sure that cost related, or actually not even cost, just medication related adherence
Mm-hmm.
is not an issue, right? It might be cost, that's a primary
Mm-hmm.
contributor. It might be access to information. How many times have we gone to the pharmacy and maybe there's an individual whose primary language is not English, and you get the monograph, the piece of drug information that comes with the medication, but it's all in English?
Mm-hmm.
Well, that information then is completely of no use to them.
It's no use.
Right.
Mm-hmm.
And so there are these barriers. Some of them are artificial barriers, some of them are created barriers, and we have to mitigate those barriers
Mm-hmm.
so that people can better understand their health and feel empowered to make a change. The change is not always linear, right? It's sometimes you're doing well, and sometimes there's a step back, but we're all human, right? And if we're properly encouraging people and they can see that these small surrogate steps are being made for this long-term goal,
Mm-hmm.
it changes people, right? The
Absolutely.
warm smile, the handshake, the hug at the end, that fills the tank for me.
Mm. So you know that this podcast is called Humanizing Us. My students who are here in the studio, they have pitched that it should be Humanizing Us with Dr. Mary J. So that next time you see it, I think we're going to actually call it that.
Okay.
But you touched on a healthcare process offered through a university that's grounded in research, evidence-based, and a history of particularly the school that you are ambassador and a leader in, the Long Pharmacy School, School of Pharmacy here at the University of the Pacific, and you ultimately got to the place where this podcast is about humanizing us. So you've taken all the gifts, your talents, the resources of the institution, and what you just described is a humanizing enterprise that creates a sense of care, um, nurturing, but empowerment for people, to be able to help determine their own lives and their own futures. Now, that was the how. I want to go down that other track that my brain was seeing. I could literally see it in my mind's eye, about a little bit about the why. And I want to do a little and invite you into a space of helping us understand a little bit about your early formation.
Sure.
Um, Tell us a little bit about your earlier years of some of the experiences that you had as a child, adolescent, young adult, um, that were really kind of foundational in some of the choices that you've made. Um, and if you can also weave in there for us, Raj, you're a South Asian man, um, a little bit around your cultural identity,
Mhm.
um, how you show up in the world physically, um, and how all of those things together, family, culture, background, race, how those things have all kind of played out in some of the experiences and the choices that led to that how that you just have told us about.
Okay.
Mhm.
So some background about me. So I say I'm an only child, but I really wasn't an only child because I had a sister who passed away before I was born from sudden infant death syndrome. So I
Mhm.
never had the opportunity to meet her. So it was really my mom, my dad, and myself.
Mhm.
I remember early as a child, my dad was an avid smoker.
Mhm.
Avid smoker. He would smoke probably a pack a day, and it bothered me because I would learn in elementary school about
Mhm.
some of the effects of smoking. And so I would take his pack of cigarettes, Marlboro cigarettes. I remember this to this day. And I would open the box and I'd take the cigarettes and I'd flush them.
Oh
But I'd
wow.
leave the box there. And then when he would find it, he was not happy. He was not happy. And I remember vividly also one birthday, my wish for that birthday that I vocalized was I just wanted him to quit smoking.
Mhm.
And he really wanted to, but he was addicted to cigarettes. So he migrated, though, from cigarettes to a pipe. Now, that's
Mhm.
not any better, but in my mind at that point, I thought, oh, he did something.
Yeah, and he was showing progress, some kind, at least progress in
Exactly,
change.
exactly. The willingness to change was there, but the
Yeah.
desire was stronger than the willingness to change. And then fast forward to my 13th birthday. And before I turned 13, I had invitations and I passed them out at school to my birthday party. At that point, Chuck E. Cheese wasn't meant for adolescents. It was
Mhm.
mostly for teenagers. There was arcade games. And I passed them out. And a few days before my 13th birthday, my dad had a massive heart attack
Mhm.
and was in the hospital. And I remember my mom was supposed to pick us up from school, and instead it was a family friend. And as we came down the street, all these kids were kind of coming to the car and saying something about my dad, and I didn't know what had happened.
Mhm.
And then I found out. And that night, she had come back from the hospital. I hadn't seen him.
Mhm.
And I remember vividly, um, I might get choked up, but I
Mhm.
remember vividly what she said. She said, if he makes it through this night, the doctor says we'll be fine. Uh, and about 2 o'clock or so in the morning, we got a call that he had a multiple series of mini heart attacks.
Mhm.
Uh, and he was in coma for a few days, and he passed away on March 1st, the day before my birthday.
Mhm.
From and heart disease is also quite high in the Southeast Asian community, and largely because there's some physiological reasons,
Mhm.
but then also our diet traditionally is very fat laden. Even though a lot of Indian people are non-meat eaters,
Mhm.
there's still a lot of oil in the diet.
Mhm.
Um, I always wanted to go in a career in healthcare.
Mhm.
So at that point, it was kind of a pivotal point because my mom was a single mom with me. She worked part time as a dietitian, and it was hard. And so there was this point in time
Mhm.
where we might have gone back to India, and I would have been raised there,
Mhm.
and my life would be completely different.
Yeah.
But it was important for her to get an education for me here, and so she made a lot of sacrifices.
Mhm.
And then I went to college, and so I was going to go into medicine. That
Mhm.
was sort of my plan.
Mhm.
And I came back, and the summer afterwards, my mom was visiting my grandmother who was sick in India.
In India. Uh-huh.
And my mom had adult onset asthma. When she went to India, she had an asthma attack, and it happened multiple times here where she had to go to the emergency room. And then she was stabilized. But her asthma was never well controlled.
Hmm.
went to India. As we know, India has quite a bit of air pollution.
Yes.
Had an asthma attack. My aunt is a nurse. They don't have a car, but they took her in a taxi to the hospital. First, they gave her breathing treatments. They gave her the EpiPen, epinephrine to open up lungs. Nothing worked. Took her in the cab to the hospital, and she was pronounced dead on arrival.
In India.
In India.
Was this in New Delhi?
No, it was in Bombay.
In Bombay, okay.
Mumbai now, yeah. And I was here, and so when I found out, obviously the family flew out there, and so both of my parents passed away before I even started
College.
Before I even started, professional school.
Yeah.
But it was because of what happened to her. I started talking to some family friends and who were physicians, and they said, good career, but work-life balance is an issue we see.
If you actually go into medicine.
Correct. So they said, why don't you consider pharmacy? Knew nothing about pharmacy, never, maybe went to a pharmacy to pick up something for her, but other than that, had very little exposure. And then I started researching it, and I thought, yes, I mean, this resonates with me. So I remember taking a book of, I think it was like 500 drugs, and for no reason, I would literally write down the name of every drug and the side effects and how it worked, and just thought that would commit it to memory. And this was before I started pharmacy school, when I made the decision to go. And then as I was going through pharmacy school, as I said, I didn't have a lot of experiential learning, at least during the 2 years before we get to our third year. But I also realized some of the need in the community. And my goal when I did my graduate work was I was going to get trained and I was going to go work for industry. I was going to go work for pharmaceutical industry. That's kind of why I decided to go the PhD route after I finished my pharmacy degree. But I noticed that I love teaching because as a graduate student, you have to facilitate some teaching sessions, some discussions, and provide some lectures. And I saw that maybe there's something here that I can actually impart some knowledge and maybe make a change on a broader scale.
Yeah.
And so I pivoted at that point and was fortunate enough right after I finished my graduate work to be offered a position as a faculty member. And in my first year as a faculty member, Medicare Part. So this is a long answer, but I'm gonna.
I'm loving this.
Get to where we came. So my graduate work, my PhD was in pharmacoeconomics, which is just a fancy word of saying really looking at the economic side of pharmacy and medicine.
Okay.
Right. And so my first year as a faculty member, Medicare Part D came into effect.
Medicare what?
Part D.
Yes.
And that was in 2006. And what Part D is for the first time, individuals who have Medicare could get prescription drugs that were largely paid for through Medicare. Prior to that, either they had to pay out of pocket or they had to get private insurance, both of which is quite costly.
Yeah, it's very costly. It's almost hard to believe that that was the case before.
Yep, and Medicare was around since 1965. So for 40 years, there was no change. There was no prescription drug benefit. But Medicare Part D at its heart is exactly what pharmacoeconomics is, right? It's looking at the cost side of medications. And most of us during our working years, even at Pacific, we have maybe 4 or 5 different insurance plans from which to choose. Sometimes that's a hard decision.
Yeah.
As a Medicare beneficiary,
you don't have anything.
You have 50, 60, 70 different ways now to get your prescription drug coverage. And so we knew, how are people, most of whom are older adults, how are they going to navigate through this sea of plans and find out how to minimize their drug costs? And that's when I started the Medicare Part D program at the school. The thought was we'll train a cadre of students and then we will deploy them in the community. So this classroom to the community model. It's wonderful to know this, but it's empowering to be able to actually impart the knowledge and make a difference. And so that's where we started the Medicare program.
Yeah. So this classroom to the community model, I love that term, by the way. I had never heard of it in quite that way before you say that, is what I have seen when I first met you. We've known each other now for 14 months. I made immediate note in my mind. I said, Raj knows how to take the students in the community, and he knows how to take the assets of the institution into the community, and he knows how to do it in a way that acknowledges the community and acknowledges their strengths and acknowledges who they are.
Thank you.
And another thing, in listening to that story, and I just want to say thank you so much for sharing that story with me. And I'm so sorry for the loss of not only your father when you sound like you were 12 or 13, the loss of your mother while she was still traveling overseas with family. And just imagining just the distance of not only losing your mother, but losing her so physically so far away. And obviously, you're a young man, you're studying in school. Um, but that those experiences, they stay with you,
No question.
you know. And as a man of color, but particularly as a South Asian Indian man, you mentioned also the dietary pieces of your own cultural background. And me being African American, I know a thing or two about the same issues, which are
Mhm.
similar.
Yeah.
Our cultures have that similar, particularly African American community, high preponderance of hypertension,
Mhm.
preponderance of the pre-diabetes and the diabetes conditions, and what you had said, how diabetes is indicators of a lot of other type of things.
Right.
And so that knowledge then also drives the choices that you make, choices that we make. And so it is not an accident, is what I'm trying to say to our listening audience, that Dr. Patel's community to classroom model exists, first of all. And then, even furthermore, the communities that you decide to go to, the ones that have been furthest left behind, the ones that have the highest marginalization, the ones that have the least investment over a period of time because of a multitude of public policy decisions and other things in society, that you go and take the uh, the medical and health services information that you have and what you have to offer as an educator, and you train other people to go into those communities. Now, I want to talk a little bit about uh, where do we kind of go from here, Raj, in regard to what we learned, particularly over the last 24 months, on what the pandemic has exposed. You knew it all along as both a scholar, teacher, and as well as a healthcare provider about the disparities and disproportionalities um, that certain groups of people were having not only in the healthcare, but we're having in society. But now everybody understands that
Mhm.
language a little bit more.
Mhm.
I feel like everybody's kind of gotten a 101 DEI lesson, if you will, after coming through 2020. And we've been forced to, unless we've had our head in the sand, to learn things that we perhaps did not know about opportunities not distributed equally. Um, and um, and if that's the case, there's a historical context to it. What must we do now to ameliorate it, remove barriers, which is a lot of your work is around removing barriers and creating access to information
Mhm.
as well as to care. Um, but there's a responsibility, though, that goes with knowledge. And now that we've kind of had this kind of, I like to call it a massive awakening, equity and inclusion issues that people can't really deny it, unless they want to deny facts.
Mhm.
They can't deny it, so we're left with this time where we have to do something with what we now know.
Mhm.
You're doing a lot through your platform as an educator as well as a healthcare provider. But maybe share some thoughts about what we must be doing now with what we have learned about disparities, not just in healthcare, but disparities across a multitude of quality of life issues, disproportionalities
Mhm.
across a multitude of issues, economic, education. And we know those things all go hand in hand with health.
Yeah.
You know that
Yeah.
um, as a healthcare leader and educator. Um, what are some things that you think is really important for us to do with what we've learned?
Yeah. It's a very thoughtful question.
Uh-huh.
I think number one, what I've learned through these years is that the community, you have to make decisions that are community informed. So as opposed to kind of creating a solution that you hope works, you
Mhm.
need to talk to those communities and the community leaders and find out what their needs are. And once you hear the needs, then to figure out how to approach meeting those needs.
Mm.
The other thing I've realized, and especially over this last year, working with so many wonderful partners that we have known about, but never worked in this kind of facilitated way before, is that partnerships are critical.
Mm.
There are things that we can do that are right in our wheelhouse, and we can do them well, but there's so much we can't do that others currently do. And to
Mhm.
find out what those services are, who provides them, how to get patients or participants or community members involved in those is critical. I wish as a county we had almost like a web page And I know we have 211, right, where we can call and find out
Mhm.
community available services. But I would love to see a web page that's a repository of all of the different services that are provided by nonprofits
Mhm.
across the county, who they are, what they do, how to make referrals, phone number, contact information. Because then anyone from the community, whether it's us or
Mhm.
community members, can go there and find
Mhm.
out, who's providing, because there are a myriad of services. And I promise you, I don't know all of them. I feel
Mhm.
like I know a good number,
Mhm.
but what about those that I don't know about? That if we
Absolutely.
encounter someone who can benefit from that, knowing that or knowing where to go to access that could help this individual. So I
Mhm.
think that's also a critical piece, is just continuing to sort of expand and understand
Mhm.
we can't think of ourselves as a silo.
Mhm.
We're larger, we're a part of this larger community.
Mhm.
And it should be that they know us, we know them,
Mhm.
and there's a trust that's been built between groups and most
Mhm.
importantly with the residents of the community.
Absolutely. You just described, if you do any study of movement work, and movement work, particularly around creating a multiracial democracy in the U.S., you start to see a lot had emerged in the 60s, when you had both kind of the Black cultural movement coming out of the civil rights, and you started to see the women's movement. You saw but you also saw cultural groups, you saw Asian American groups, gaining political voice, trying to find ways to um, uh, create their, unique role and contribution in the country. We saw the Latinx community at the time, Mexican American, oftentimes leading the way. We saw a lot of leadership coming out of the United Farm Workers Movement.
Mm-hmm.
Dolores Huerta, who will be on campus later this month, we'll be talking about that. She's one of the greatest leaders of all social justice leaders of all time.
Mm-hmm.
But you saw Filipino Americans, but it was a very rich time. When you look in the '60s of these groups that had historically been marginalized, and they begin to do work. If you really study it, and as a equity scholar teacher, I'm always reading about the historical pieces, particularly these moments in our society, when we made movement, um, and this idea of solidarity making, to do things with and among each other for the sole purpose, even as each one of those groups had maybe their own list of things that they wanted, but if you put their list together, it was actually all the same thing.
Mm-hmm.
Do you see us? Do you know we matter? And can we have a voice in our own pursuit of life, liberty, and the pursuit of happiness? These ideas of self determination.
Mm-hmm.
Um, when you talked about all the work that you're doing, it's at the very core of what has always been um, the key to creating a multiracial democracy where everybody has a chance to live their best and highest lives and selves. So you're practicing it through the platform of being an educator as well as I think you're also a practitioner, clearly you're a clinician, as a clinical provider. How do we do that work? How do we magnify that work? How do we animate that work with the next generation?
So I'll answer this. I'll give you
Hmm.
some historical perspective about what I thought, and then
Uh-huh.
answer your question, maybe
Yeah.
through a little bit of a novel approach. So I grew up in Southern California,
Hmm.
and my schools, whether it was junior high school, elementary school, high school, were quite diverse.
Hmm.
Just different races and
Hmm.
ethnicities, and back in elementary school, we even had busing,
Hmm.
where kids would come from the inner city, and we would send kids there for particular years. Um, didn't really think about like they're Asian or they're African American or they're Hispanic, because there would just be commonality and
Hmm.
interests. Like we like sports, so there'd be people who'd play sports, or
Hmm.
we'd like to do, there'd be art, and so the activities were the commonality.
Hmm.
Then I got to college,
Hmm.
and what I noticed is that you had an Indian club,
Hmm.
and you had an African American club, and you
Hmm.
had and so on. And what would happen is that at lunch in the cafeteria, people would sit with people from their groups.
Yeah.
And there was this automatic sort of segregation.
Mm-hmm.
And it really bothered me.
Yeah.
It really bothered me because I think a lot of discrimination comes from you just don't know someone that's different.
Yeah.
And it's because you don't know that you sort of hear and fill the gaps, and they're not good because you don't have any experience with that person or that race or that ethnicity or whatever the case might be. And it honestly started dividing people. So back then I thought about this, and this is one thing I wanted to talk to you about, is that we have similar groups here, but what happens if annually they had two different groups had to work together on an event that maybe served both cultures or both, diverse populations, but working with each other for a common goal, I think breaks down barriers. Then it's not, they're Filipino or they're African American or they're Indian. They're just people that we worked with to put something on together, and there could be this sense of pride in serving the community. And I think it would help decrease the barriers and help educate one another about the other's differences, their cultural differences, their gender differences, their race, whatever the differences might be. But that's something that really struck me from being a young boy at school, where I didn't really see any of that, and I'm sure it existed.
Yeah.
But not did I consciously see that happen really at all. But then I noticed how different it was
at the university.
Yeah, as I got older, and at the university, and so I sometimes I feel like we create our own barriers.
Yeah.
So yeah, and we all are different, but if you strip down the differences, at our core, we have the same basic needs.
We do.
Right? We have the need to be loved. We have the need to be fed and sheltered and secure. And so I don't know. I just view people as different. You take away what you see, and really what they need or what they're communicating is no different than what I need or what I would communicate.
Absolutely. Dr. Beverly Tatum, a former president of Spelman College, and real thought leader in higher education, she wrote a seminal book. I think it may have been first printed in the 1980s or 90s. It was called "Why Are All the Black Kids Sitting Together at the Cafeteria?"
I did not know about that book, but you know what? I am going to read that book now.
And it was one of her takes as I think she's a trained clinical psychologist, on the very issue that you're getting at. And there's a book on race, and it's talking about how race as a social construct kind of creates these socially constructed behaviors, and how oftentimes then in these new environments, i.e. in a university or college environment, that when individuals go, they're trying to find a way not to only to have a sense of belonging, because everybody needs a sense of belonging, but they're also trying to figure out, particularly if they're a minoritized group in that community, how to belong.
Sure.
And so, so she really kind of delves into the social construct of race, because we were not Black until, my ancestors, I'm a descendant of a formerly enslaved people. Our Blackness was created in opposition to the whiteness of the individuals who were our captives. So Blackness is, Black people in Africa they're just Black, but Black is not anything,
Right.
like being brown in India is not a thing,
Right. Yeah,
everybody is. We didn't get Black until we actually came here.
Right.
So this idea then is, the social construction of colorism, the social construction of race is all socially constructed. These are not biological facts.
Right.
Race is 100%.
Right.
All of our social scientist colleagues have proved that over and over again, as well as other scientists have proven that over and over again. So these are socially constructed environments that then have socially constructed behaviors.
Right.
And what you're saying is that you're thinking about going from your adolescent, Raj, to be now a young university student. These constructed behaviors still persist. Why do they persist?
Right.
And then what can we do to break down the barriers to create more humanizing experiences?
Right.
And that's exactly what you're doing. And that's exactly the work that we're trying to do.
Oh, thank you. Yeah, no, I think When serving communities, we try to make a targeted effort to make sure that we reach different types of communities, different races, ethnicities, different languages, different. Berkeley, we've gone to many years at the Ed Roberts campus. That entire campus is for individuals with disabilities, all of the agencies and services there. And so there was one year I remember, and I'll never forget this. We thought what we need to do is we need to make sure all of our documents are provided in Braille. We've never done that before, right? And so we did it. Every vaccine information sheet that you would get, when you get a vaccine, regardless of setting, every screening document, and so on. Lady comes in with her daughter, adult lady, probably in her 40s. Daughter was probably a young, maybe a young teen or under 10, and she got the vaccine, and we gave her the vaccine information sheet in Braille, and she said, and she was again probably in her early 40s, in all of her years, and she would get the annual flu shot. In all of her years, it was the first time she actually got information in a language that she could understand. Right? She could actually now understand what to expect, what side effects were. She already had the experience of having the flu shot for decades, but the first time you actually get information that's accessible.
And the accessibility was a humanizing gesture. It was a humanizing act. It was a humanizing saying, by the way, we know you're here and we are making sure that we know that you know.
Right.
You matter.
We try to be very conscious in things like that, right? When we have tables, we make sure that there's enough space separated from the tables, not only for privacy, but if someone is coming in a motorized vehicle or they have a cane or a walker, that they don't have to worry. Like they don't have to try to squeeze through. Or when they're seated, we make sure that someone's behind the chair stabilizing it so that the chair doesn't tilt and they don't have to worry about a potential fall. And the same thing when they're getting up, right? Small gestures, but understanding that we're trying to meet their needs. When we have cords, we try to tape them and make sure that the students don't walk in front of them. They walk side by side so that they are their eyes and ears, right? So that there's any trip hazards, the students can alert them. Like, be careful here, let's walk slowly, hold their hand if necessary. Those small kinds of things, right? Making sure that they're sort of the center of what we do, and we're very thoughtful in how we provide not only the care, but in how things are set up for them.
So you know that I created a framework that's based upon a lot of other work that has happened, but I called it the DEI Framework for Excellence for Pacific. And one of the things that I say in that is that fundamental to doing equity work is that you have to decenter the very things that you want to center, and you have to put in the center the very things that we oftentimes overlook. And you just described in your manifestation of how do you go about doing this work, and the example that you gave, particularly for persons with disabilities or persons that may or may not have disabilities, but they perhaps may be elderly. They may be have vulnerabilities that you can see and some that you may not be able to see, right? This idea of centering the needs of the vulnerable or centering the needs of those who maybe are not vulnerable, who can become vulnerable because we have not centered their needs. This idea of humanizing us is actually doing the work that you're doing, Dr. Patel.
Thank you. I will just say this. For me, and whether this is in the classroom setting or the community setting, I have a very simple philosophy. Just treat others the way you want to be treated. That's it. That's it. If you do that, I think you should always be fine. Just treat others the way you want to be treated. And if people are conscious and they do small things like that, some of the most profound things that have happened in my life, complete strangers. Complete strangers. I can give you a story where we were in Mexico. We were at a resort, and what we decided to do was take a taxi, an air-conditioned taxi, to go to a tourist destination, thinking that it will save time. We don't go on the tourist bus. Well, on the way back, the taxi broke, and we were about 30 miles from the resort. And it was the middle of summer, probably 105 degrees, searing heat. And this was back before cell phones were commonplace, about 15, 20 years ago. And how are we going to get back? So it was there was no way we were going to be able to walk, or so we hitchhiked. literally hitchhiked. There were tour buses that stopped. We even offered to pay, and they couldn't. They wouldn't take us. And ultimately, three different hitchhikers, three different individuals basically took us. And then the last one, now, mind you, there's three of us. It is really hot, and we are just
Sweating.
dripping wet. Our shirts are sort of tied around our waist. We're dirty and smelly. We've been out there probably an hour. And this gentleman, it was a dad who had a son that was probably about 5 years old. He stopped. And we had about 2-3 miles to go to get to the train station, to get to the bus station, to get the bus back into town. He stopped and he took the three of us in the back of his car. Now, I can promise you, I would never stop for three people like in a different country. Like I would just not know the security of my son and whether this would be okay. But he did that. And he took us, and he wouldn't even allow us to thank him and give him anything. We ultimately, before he drove away, we put money in the back seat and said, get something for your son. But the kindness of strangers, for this gentleman to not know any of us, to pick up three, at this point we were in our 20s, early 20s, late 30s, early 30s, late 20s, and to take us to a bus stop just because he saw that we were in need, that's an unbelievable act. It's the most selfless act that I've ever had someone do for me. Don't know the gentleman, don't know anything about them, and likewise, they know nothing about us. But that will have an imprint on me forever, right? Those acts of kindness, where someone just does something beyond what most of us would do. Wow, yeah.
And then what you do each day is that you pay that forward in the classroom.
Absolutely try to set an example and so that others can make that same kind of impact on the life of someone else.
And I know you're a father too.
Two young ones, a 5-year-old who's going on 20 because she thinks she knows everything and can do everything, and then
she's brilliant.
a 15-month-old who just started walking, but he gets bullied by his sister. But I told her, just wait till he gets old enough because he'll sit on you, and then good luck, my friend. So
I love that. Well, I have completely enjoyed thoroughly this conversation with you, Dr. Raj Patel. Full professor in the Long School of Pharmacy at the University of the Pacific, a leader in the classroom, but even I think he's a giant in the community, and he's helping us to think about how do we do this DEI work, this social justice work, using the university as a platform for good. And I want to thank you for everything you're doing and being a model in that work.
Well, I want to thank you for your work in the community, in the school, and the university. You've been here a short time, profound impact already, and a lot of us have noticed. And so thank you.
Thank you so much.